So good evening, everyone. If I'm visible and audible, give me a thumbs up on the chat box. Good evening, everyone. If I'm visible and audible, give me a thumbs up on the chat box. Good evening, everyone. If I'm visible and audible, give me a thumbs up on the chat box. Good evening, everyone. If I'm visible and audible, give me a thumbs up on the chat box. Good evening, everyone. If I'm visible and audible, give me a thumbs up on the chat box. Good evening, everyone. If I'm visible and audible, give me a thumbs up on the chat box. Good evening, everyone. If I'm visible and audible, give me a thumbs up on the chat box. Good evening, everyone. If I'm visible and audible, give me a thumbs up on the chat box. Good evening, everyone. If I'm visible and audible, give me a thumbs up on the chat box. Good evening, everyone. If I'm visible and audible, give me a thumbs up on 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 audible. Dr. Jayashri. So good evening, everyone. Good evening, everyone. If I'm visible and audible, please let me know. I can't see any messages, just waiting for your messages. Otherwise, I'll start with the session, the revision part. Yes. Okay, so Dr. Blessing M. Finally, I got one message there. Audio and video is fine, said by Dr. Blessing M. Good. So let me just start with the session then. Okay. Nice. So finally, I get to see the messages. Okay. So we'll start with the anesthesia revision part of it. Good evening, Dr. Med Psycho. All good. Nice to see you. Good to see everyone. Good to see all the guys now. Okay. So let me start with the session, and in between, you guys can keep on. I'm doing fine, Dr. Med Psycho. Right. I'll not be taking it in the form of MCQs. Right. Okay. What I'll be doing is I'll be discussing all the important points from anesthesia in the next 45 minutes to 1 hour that we have. Right. Dr. Parul Patel is also saying good evening. Good evening, guys. Good evening. Okay. Good evening, everyone. So if it's okay with all of you, I'm just going to discuss the important points from anesthesia. Let me just discuss where should you people concentrate upon. Remember, CPR is the most important point on which questions are being asked recently, whether it was FMGE, NEET, PG or INI-CET. I'm going to cover this a little bit in detail, right? After that, what I will do is I'm going to go into the other topics where recently questions have been asked, which were the previous year's questions and where people have concentrated. I'm not saying other questions can't be asked, but I will concentrate on CPR. I will concentrate on oxygen delivery devices. You people know Venturi mask, non-rebreathing mask have been asked in the exam. We will discuss a little bit of monitors on which questions have been asked. And let's see how much we can finish. We'll try to finish off or the revision of anesthesia in the next 45 minutes, right? We'll try to finish off. It's mostly image based also, so that your images from anesthesia also get done. And if I'm asking, you can just text the answers. I'm not going to take it in the form of questions, right? Dr. Success says yes, sir. Right. Let us go forward. So let me start with the first point. If there are any doubts, you can ask me. The first thing that I'm going to discuss with you is CPR. Remember, in the steps of CPR, right? It's a very important point. This is the American Heart Association 2020 guidelines, right? There's few modifications which come off and on, but the basic guidelines remain the same. They don't change. The first step in CPR is always to identify the scene safety. Remember this. Scene safety means everything is safe, everyone is safe, you are safe, take standard precautions. After that, the next step is check for response, whether the patient is responding or not responding. If the patient is not responding, then you go forward, right? That's the next point. And then you're supposed to do basically call for help, activate the emergency response, get the automated external defibrillator and emergency equipment. So scene safety, check for response, and then call for help and activate the emergency response system. Till now, remember, we have not checked the breath and pulse. Once you have called for help, right? Once you have called for help, then you look for the breath, then you look for the pulse, right? The breath is looked by the chest rise that you see in the patient, and the pulse which you normally feel is the carotid, right? This is what is to be done, and this is to be done simultaneously within 10 seconds. In 10 seconds, if you can feel the breath, if you can feel the pulse, that means both are positive. Chest rise is also there, carotid is also there. In that case, just keep the patient in the recovery position. This was the question asked in NEET PG with a diagram like this. Okay, so when the pulse is there and when breathing is there, just keep the patient in recovery position. After that, in case you find that the breath is absent, right? Now what has happened? The breath is absent, but the pulse is there. The next point, if breath is absent and pulse is there, what you need to do? What is absent? Breath. So in this case, you will keep on giving breath to the patient. Keep on giving breaths, right? So they've said you keep on giving breaths to the patient. One breath is supposed to be given every 6 seconds, or you can do it as 10 to 12 breaths per minute. Check pulse every 2 minutes. If no pulse, then you start CPR. Point is, in this case, breath was missing. Keep on giving the breaths. That's point B. So now, first point, pulse felt, breathing felt, you keep the patient in recovery position. If one of them is there, as in breathing is there and pulse is not there, you just give the breaths. Third point, in case there is no breath, in case there is no pulse, this is where you start CPR. Okay, that's the next point. When you give CPR, what you're supposed to do? You're supposed to give chest compressions, right? You're supposed to do airway maneuvers so that the obstruction can be removed. So chest compression, then is followed by airway, and then is followed by breathing. So what you're doing is basically C, A, and B. This is delta. Chest compression is basically, again, this question has been asked recently. High quality chest compression, 100 to 120 per minute, right? The rate is 100 to 120. The depth would be 2 inches to 2.4 inches or 5 to 6 centimeters, right? Allow for the recoil of the chest. And where you're supposed to do? This is lower 1/3 of the sternum. Airway. How do you remove the obstruction? Now, Dr. Metsyko, I'm coming there. Wait. How do you remove the obstruction? This diagram was asked in the exam. Head, tilt, chin, lift. And this is not supposed to be done in fracture cervical spine, where you will do jaw thrust. So this was what being done is head, tilt, chin, lift to remove the obstruction, which is the tongue falling back. And after that, you start giving the breaths, right? When you give a breath, it can be mouth-to-mouth breathing. It can be mouth-to-mask. It can be bag mask ventilation, right? Or the bag ventilation. Correct. So now what is there? You have to combine all of them together. So you are supposed to do cycles of 30:2, as Dr. Metsyko says, right? In a span of 2 minutes, and keep on continuing it, right? So this is what was done. So this is head, tilt, chin, lift, and this is what is called as jaw thrust. So this was the question asked in exam: head, tilt, chin, lift, and jaw thrust, right? Correct. Dr. Metsyko says jaw thrust for trauma. As I said, we have started the CPR. 30:2. Normally everywhere it is 30:2, except pediatric patient. When there are 2 rescuers, it becomes 15:2. Remember this point, right? Until now, you didn't have the defibrillator, automated external defibrillator. When you get that, you assess the rhythm. In case the rhythm is shockable, you give the shock. After the shock, no pulse check. Important point, do not do a pulse check. Immediately start CPR. And what you're supposed to do, continue the CPR till ACLS providers arrive or victim starts to move. In case the rhythm is not shockable, what to do? Nothing. You can't give the shock here. So keep on continuing your CPR till the time advanced life care supporters arrive or victim starts to move. Thumbs up, everyone. Point clear. That was CPR in short. Almost everything done. Thumbs up, guys. Thumbs up. Okay. Okay. So fine. Let me go to the next part. ACLS in short. ACLS means airway, breathing, circulation, disability exposure, or you can say diagnosis, either of that. It means here airway is secured. You have put an endotracheal tube, you put a LMA. Breathing, you will keep on giving breaths. Now you realize airway, when we speak of ACLS, in ACLS, it means your airway is already there. Someone has put endotracheal tube, someone has put laryngeal mask airway. So you keep on giving breaths at the rate 10 to 12 per minute. This was a question this year's NEET PG. This question, right? Keep on giving the breaths. What about circulation now? You have to continue your CPR, but remember breathing and circulation, that 30:2 is not there. They are independent of each other now, and CPR will keep on continuing at 100 to 120 per minute. You keep on giving breaths at 10 to 12 per minute. At the same time, circulation. Now you have ACLS providers. You are going to take intravenous access or intraosseous access. This intraosseous was also a image-based diagram which was asked recently, right? Recently, yeah? This is the INICT if I'm not mistaken. So intravenous or intraosseous access is there. What are the drugs you can use? You can use epinephrine or adrenaline. You can use amiodarone, and you can use lignocaine. These are the only drugs that you can use. Other drugs are not to be used. Now these are ACLS providers. You can give a shock. You have a defibrillator. It's not automated external defibrillator. You have a proper defibrillator now. You can give a shock. So if it's a biphasic defibrillator, 100 to 120, sorry, 120 to 200, and monophasic 360. If you don't remember this, it's okay. So let's forget that. More important point, CPR quality has been asked in exam. As I said, it has to be 2 inches to 2.4 inches, 5 centimeter to 6 centimeter, 100 to 120 per minute. Allow chest recoil. Okay. Minimize interruptions in the chest compression. Avoid excessive ventilation. Change the compressor every 2 minutes, right? And if you don't have endotracheal tube, then keep on doing 30:2. But if you have endotracheal tube, don't do 30:2. They are independent of each other. Dr. Med Psycho says cardioversion for unconscious or unstable. No, Dr. Med Psycho, see, cardioversion and defibrillator are different. So here defibrillation means you're just going to give a shock. What are the shockable rhythms? So basically the two shockable rhythms where you can use that defibrillator is ventricular tachycardia and ventricular fibrillation, right? So what will happen is, in this case, let's go back. Let me show you here. In what are the rhythms which were shockable? These were ventricular tachycardia and ventricular fibrillation. You were supposed to give a shock here. But if your rhythm is pulseless electrical activity and asystole, flat line, you are not supposed to give a shock. Here is where you use that adrenaline, right? This is where you use adrenaline. Okay, so and this can be repeated every 5 minutes. Right, Dr. Ajila, Dr. Med Psycho, all of you correct. I got a thumbs up from Dr. Noor Alam and everyone. Okay, so that is CPR in short. Any questions and doubts, ask me. Remember, at the same time, you have to keep on thinking about the 5H and 5T. What are the causes? So disability exposure, that D stands for disability, okay, prevention or exposure. At the same time, it stands for diagnosis. So you keep on thinking the reversible causes of 5H and 5T. Thumbs up, guys. Thumbs up, everyone. Fast. Then we'll go to the next point. That is CPR in short. And it is the most important topic coming from anesthesia. People are going to ask you questions on CPR for sure. Okay, for sure this is going to be there. Something will be there from CPR. What will be there, we don't know, but something is going to be there. Next. Okay, identify. What is this? I'm not giving any option. Just put it on the chat box. Right, I got a thumbs up from everyone. Fast, because I want to discuss all the images with you. Fast. What is this? Image-based diagram. Jaldi. Fast answers. Anyone? Right. Dr. Noor Alam says CVP line. Very nice. This is CVP line. CVP line is a central line. Central line is put in a major vein of the body. The most common is internal jugular vein. You use the subclavian vein. We use the femoral vein. We can use the basilic vein, and we use the cephalic vein, right? More commonly. Point is, these are all veins, not artery. The tip lies where? At the junction of superior vena cava and the right atrium. Important point. What does it do? It helps you to measure the CVP. You can give total parenteral nutrition, chemotherapy, pacemaker, dialysis, major surgery, cardiac patients, neurological patients, ICU patients, everywhere. Okay? Basically, what does it tell you? Central venous pressure or the fluid status. CVP normal is 8 to 10 centimeter of water. Commonest complications, you are in the vein. So therefore, the next is the artery. You can rupture the artery. You can cause arterial rupture. You can cause heart rupture. In IJV and subclavian, you can cause pneumothorax on the right side, on the left side. But On the left side, a common thing can be chylothorax. This was INI-CT question. While inserting a central line, this image was given and this was chylothorax, thoracic duct. Okay, so this is a complication, especially on the left side for the central line. Remember this point. Okay, it's a major complication on the left side central line. Thumbs up, guys. That's central line. Let me go to the next point. Okay, next one. Identify. What is this? As I said, I'm discussing all the important points, especially the ones on which questions have been asked recently. I'm not going to a lot of those details, other things, drugs and all. I know all of you know drugs on everything you people keep on studying, but let me discuss those points on which questions have been asked recently. These are all previous years ones. So, right, Dr. Ajila says ABG. ABG nahi. ABG to ye dikh gaya. Sorry. What is the second diagram then? Right. This is arterial blood gas collection. That is the first. Correct. Though I meant something else, but theek hai. What is the second diagram then in that case? If first is ABG, Dr. Ajila. Agila. Sorry, if I'm not mistaken. The second image that you see is basically what is called as arterial line. And this was again NEET PG recent question. They had asked you this thing, which is called Allen's test. Okay? NEET PG tha ki INI-CT? I think INI-CT. I'm not sure. Whichever exam. Allen's test. Okay, where you're checking the patency of the collateral supply. Okay? Ulnar and radial ka. When you're putting an arterial line. So this is an arterial line. It is put in an artery, not in a vein. So which can be the radial artery, it can be the ulnar artery, right? There can be the brachial artery, femoral and dorsalis pedis, right? What does it tell you? Blood pressure measurement, invasive. Okay, and you can do ABG collection from there. That's it. You don't inject any drug in the arterial line. That's it. Okay. Next, identify. No, identify. Everyone knows. Let me discuss. This is the IV cannula, intravenous cannula. So remember, the pink one is 20 gauge. The blue one is 22 gauge, yellow one is 24 gauge. There's another purple one which is 26 gauge. These normally are thin, right? The green one is 18, gray is 16, and orange is 14, and they are thick ones. Remember this point. So if it is thick, this is going to be used for blood transfusion or fluid transfusion, right? Basically resuscitation, blood resuscitation or fluid resuscitation. You want to give fluid to someone has lost a lot of fluids, give this fast. Someone has lost blood, use this, right? 20 gauge is the most common used in adults, right? 22 can be used in adults and pediatrics both. 24 is normally used in pediatrics, sort of in neonates, and 26 is used in neonates and preterm neonates, right? Mostly used in the OPD and ward is green and pink. No, remember the mostly used is pink, not the green. Green is again coming for blood transfusion because the flow rate is around 80 to 90 ml per minute, right? 50 ml per minute. This is pink one. So most common used is the pink one, most common in adults, right? Dr. Med Psycho. And 18 wala jo hota hai, 18 gauge is basically, again, all these three are used for blood and fluid transfusion. These are used for pediatric patients. Okay? I think IV can also done. Next question. Here, important points. I'm going to discuss oxygen delivery devices. Again, all these are previous years. If you see whether it is INI-CT, whether it is NEET PG or FMGE, each and every point that I'm discussing has been asked either as an image-based diagram or otherwise. Okay. So I'm discussing all those points which covers your previous years and the questions where people are focusing now. I'm not saying questions can't be asked on halothane, desflurane, sevoflurane, but you people already study that. These are image-based questions. These are easy questions and they overlap with other branches. So I'm discussing that. Forward. Now, the next thing is we'll discuss those oxygen delivery devices. So remember, I've discussed this before also. Oxygen delivery devices are classified into two types, basically three types, but I'm for easy, to make it easy. Let's make it two types, low flow and high flow. Okay, low flow and high flow. What are low flow devices? So whether you see the nasal cannula, this is low flow, simple face mask, low flow, non-breathing mask, low flow. But when you see high flow nasal cannula, high flow, Venturi mask, high flow. So these are the high flow devices. Let's discuss the low flow. Nasal cannula is a low flow device. This is what a nasal cannula. The maximum FiO2 that you can give from here is around 40 to 44%. Right? In a simple face mask, maximum oxygen would be 60%. In a non-rebreathing mask, it is something which has a reservoir bag. You can identify from the reservoir bag behind the mask. Okay, so this non-rebreathing mask can give up to 90%. This is what gives the maximum oxygen or the maximum FiO2. So in case someone's saturation is falling down and they ask you which is the device which gives the maximum oxygen from the low flow devices, that is going to be non-rebreathing mask. It gives up to 90%. Okay, then this is what is called as high flow nasal cannula. So if you will see, it is given from a bigger machine which looks sort of a ventilator or a humidifier, right? And the cannula, nasal cannula, is much more thicker. If you see, Dr. Med Psycho says non-rebreathing mask most common used in COVID time. Yes, Dr. Med Psycho, absolutely correct. This was the normal nasal cannula, and this is what is called as the high flow nasal cannula, which is much more thicker. The advantage with high flow nasal, even this was used a lot during COVID, Dr. Med Psycho, other students. This was used a lot. This can give up to 100% oxygen, but do you know the oxygen flow rate here has to be around 60 liters per minute. That's why it is called high flow. If you take non-rebreathing mask, here the oxygen flow rate is normally maximum 15 liters. In a simple face mask, you keep it around 10 liters. In nasal cannula, you keep it around 6 liters. So 6 liters give 44%, 10 liters give 60%, and 15 liters of oxygen gives 90%. Here it is 60 liters that gives 100%. Okay, so that is high flow nasal cannula. The last from oxygen delivery devices are again the important ones. In the last 3 years, two questions have been asked. 2 times the questions have been asked from Venturi mask. This is what is called a Venturi mask, and Venturi mask gets attached behind the normal face mask that you see. It's a small device gets attached. What does it do? It has a small opening over here. This opening causes air entrainment. Air entrainment means oxygen is coming from here, air is coming from here, and air goes inside, right? And because of the constriction produced, it pulls in air from here because of the holes which are there, right? And this, though it is a high flow device, remember the only advantage of this device is that it is fixed output. What is fixed output? Fixed output means you know which color you are going to put, and that color gives you that much oxygen. If I put the green one, it is going to give 60%, and this is the maximum. If I use the blue one, it is 24%. If I use the red one, it is 40%, right? So Venturi gives you fixed FiO2 depending on which mask you're attaching. It's a fixed output device. Again, this has been asked in exam. It is based on the Venturi principle or the Bernoulli's law. Okay, thumbs up everyone. Okay, so we finished the oxygen delivery devices also. Next point, let's discuss a little bit about intubation. Okay, so all these are those topics, general question types, miscellaneous. You can also say I'm discussing all the miscellaneous questions today. Right? Intubation. Endotracheal tube is put in the trachea. So this is what is called oral endotracheal intubation. The next one is put from the nose. This is called nasal endotracheal intubation. Right? Now, most of you know everything. I'll discuss a few points from here also. But remember, the question asked in nasal endotracheal intubation. So when you're putting a nasal tube, where not to put the nasal tube? If there is fracture base of skull. Fracture base of skull, don't put a nasal tube. CSF, rhinorrhea, don't put a nasal tube. If there is a swelling in the nose, don't put a nasal tube. Swelling means what? That swelling will be a nasal polyp. It may be a adenoma. There may be a deviated nasal septum. There may be not there, but maybe a nasopharyngeal or maybe a retropharyngeal abscess. Don't put a nasal tube. These are contraindications to nasal tube. Okay, where not to put the nasal tube. All right. Let's go to the intubation. When you do a laryngoscopy, the position is called sniffing position or McGill position. Please remember, it is not called the Rose position as most of you think. Okay? It is not the Rose position. It's called sniffing position. What happens here? There is an extension of atlanto-occipital joint, flexion of the lower cervical spine, right? So head extension, neck flexion is what you get. And the 3 axis, oral, laryngeal, pharyngeal, they come in one line. Thereby, you can see the vocal cords much more easily. That's about the laryngoscope. This is what is called as a, okay, anyone? Name them. Which laryngoscope is this? A1. It is A. Which laryngoscope? Name the laryngoscope. And used where? Two things I'm asking. Name and use. Laryngoscope number A. Dr. Med Psycho says Rose position ENT. Yes, Dr. Med Psycho, absolutely correct. Rose position is in ENT. This position is called sniffing position or McGill position. Some books have also mentioned it, not books, but I say people also call it barking position. कुत्ता भौंकता भी तो ऐसे ही है. The dogs bark like this. Anyone? Fast, yeah, fast, guys. So I want to discuss all these diagrams with you, right? All these images, so that your image revision is done from anesthesia. Dr. Agila says straight. Very nice. It is the straight blade. But what is the name? Very nice. It's the straight blade that you're seeing. Dr. Agila says other is the curved. Correct. This is the curved one. Correct. But tell me the use and the name. Med Psycho says Dr. Agila is right over here. Huh? Dr. Agila. Straight blade. The first diagram that you see is the straight blade. It is called the Miller's blade. It is used in pediatric patients. The second blade that you see, B. This is called the curved blade, and as Dr. Med Psycho puts it, this is Macintosh, and this is used in adults. Okay, this is the laryngoscopy. So when you do a laryngoscopy, remember your laryngoscopy can cause damage to any of the structures over here, epiglottis. I'm not going to those details. It can cause damage to the cervical spine. Okay, hemodynamic response can be there. A lot of these complications can be there during laryngoscopy and intubation. When you intubate someone. The next point is the endotracheal tube. So now remember, this is what is called as the machine end or the connector. This point that you see over here is what is called as the bevel. This, what you see over here, is what is called as Murphy's eye. Important question. It has been asked also. Small opening that you see here like this. It is called as Murphy's eye. It is an additional port for ventilation. Right? This is called as the vocal cord marker. This is supposed to lie at the vocal cords. Okay. This is called the cuff. And the cuff is inflated from the balloon, from the inflation line. This is the inflation line from where the cuff gets inflated. This cuff that you see is a high volume, low pressure cuff. Important point. You inflate with 5 to 10 ml of air, but the cuff pressure should be less than 30 centimeter of water. This is the internal diameter, and internal diameter is the size of endotracheal tube. Remember, the resistance of endotracheal tube depends on its ideally radius according to the definition, but most of the times in the last 3 years, when this question has been asked 2 times in FMGE, they have not given radius, they have given diameter. So resistance of the endotracheal tube ideally should be the radius, but they have asked as the option diameter, so we will go with diameter, right? The size of the endotracheal tube is its internal diameter, and resistance depends on the radius, but then we will take it as diameter because that was the option given in the exam. These markings are called centimeter markings, which you see in a male patient. 21 to 23 is at the lip in a male patient. 19 to 21 is in a female patient, right? So this tells you how deep you're inserting in the patient. Vocal cord marker as well as this centimeter markings. Okay, everyone. There's one more point last. There is this radio opaque line. This was again a question asked in the exam. Radio opaque line, blue colored, which can be seen on the X-ray, so that you can identify how you placed your endotracheal tube in the patient correctly. Thumbs up, everyone. That's the endotracheal tube. We discussed the laryngoscope also. So let me go forward. At least the instruments and all we will finish. Yeah. Okay, thumbs up, guys. Now, important instruments now. We'll finish them fast. The first instrument that you see is what is called as the classic LMA. If you can see, there's a single tube here. There is a cuff over here, right? And this classic LMA is also called the first generation LMA, because from here, you cannot give IPPV to the patient, because if you put the LMA, what will happen is some oxygen will go here, some will go here. This will inflate the stomach and can cause aspiration. So therefore, you cannot give IPPV. So they made a new LMA, and this is called as the Pro Seal LMA. So procele LMA or laryngeal mask airway. Why is it called laryngeal mask airway? Because the laryngeal mask airway, it is going to lie in the larynx. It's lying in the larynx. Can you see the tip lies at the esophagus? Okay, it's lying at the larynx. The tip is lying at the esophagus. All right, and therefore this is called as the laryngeal mask airway. It's also called as the supraglottic airway. Okay, it's also called supraglottic. Procele. What is the advantage? They have given you a drain tube, and from the drain tube you can put a Ryle's tube that goes inside the stomach. So therefore, now you can do a suction from here. From the drain tube, I can do a suction from the drain tube. And therefore, I can use it for IPPV. So this is called as a second generation LMA. Second generation. The third device you see is iGel. Right? In this case, there is no cuff. There's just a gel that takes the shape of larynx. And they have provided you a channel for the Ryle's tube to go from here. So iGel also becomes a second generation LMA. It can be used for IPPV. Hopefully all clear to everyone. Okay. Laryngeal mask airway also done. This is what is called as oropharyngeal airway. This is also called Giddle's airway. Okay. Some people call it mouthpiece. Right. It does not have a tube, airway tube like how the LMA had. LMA has a tube from where you can give oxygen, you can put a breath, you can give, give breath to a patient. And that is why endotracheal tube and LMA, if you find LMA is almost an alternative to endotracheal tube, and it has been included in the CPR also. If you remember ACLS, I only told you airway, you can either put endotracheal tube or LMA. It has been included in the CPR also, right? But oropharyngeal airway is not, it's not a way where you can give oxygen. With oropharyngeal airway, in case of CPR, you have to do a bag mask ventilation. Means ambu bag ventilation. Right? So it basically what it does, prevents the backfall of tongue. Okay, that's the point. And the size of the tube is where? It's from the mouth to the angle of mandible, and this is the size of the oropharyngeal airway. Okay. Next device. This is called as nasopharyngeal airway. Nasopharyngeal airway. The size is from the tip of the nose to the tragus. Okay. It does the same thing, prevents the backfall of tongue. Biggest advantage is that I can use this in an awake patient. Right? That's an advantage because it does not stimulate the gag reflex. Oropharyngeal airway is contraindicated because it stimulates the gag reflex. Thumbs up, everyone. Is that okay? Okay till here? Everyone okay? So this is what is called as bag mask ventilation. Okay, ambu bag ventilation or bag mask. So they have asked you what are contraindications to bag mask ventilation. Like where we'll not try to do a bag mask before surgery, not before in CPR. If someone is dying, you have to do bag mask, right? Or ambu, correct. So it's ambu bag ventilation. Okay, I'll rather put it as ambu bag ventilation. You're right. But what are the contraindications to a similar thing, which is bag mask ventilation? So all the full stomach conditions or the risk of aspiration conditions, you will try to avoid the bag mask ventilation. So in a full stomach patient, what do you do? In a full stomach patient, guys, we intubate in such a manner which is called as rapid sequence induction. In a full stomach patient, what we need to do is we do cricoid pressure. This was again asked in the exam. You use a cricoid pressure of 30 Newton. This process is called Sellick's maneuver, or this maneuver is called Sellick's maneuver, where someone is putting cricoid pressure, then someone does a laryngoscopy, someone is putting a pressure on cricoid, and after the laryngoscopy, you intubate. Once you have intubated, you have confirmed, only then remove the cricoid pressure. That is done in full stomach patient, cricoid pressure or Sellick's maneuver. So done with intubation, done with all these devices, right? Identify what is this device. As I said, I'm taking all the images as much as I can. That will finish, okay? Hopefully your revision will be done from the image point of view and the important questions here. Right? Dr. Ajila says 2He needle. Very nice. So this is your epidural needle, which is called the 2He needle. You can see it has got 1 centimeter markings to tell you how far you are from the epidural space. Right? So this is the 2He needle, which is the epidural needle. It's got a curved tip and you can pass a catheter. Compared to a spinal needle. So remember, a epidural needle is thick in nature. it has got 1 centimeter marking. This question was asked in the exam, 1 centimeter marking, right? And this is a thin needle comparatively. Here also, now this is a spinal needle. This what you see can be called as a LP needle, lumbar puncture needle, or a spinal needle. This can be divided into two types. One is dura cutting, other is dura separating. So let's see that. So this what you see is called an epidural needle, right? This is the catheter going from there, 1 centimeter marking. Spinal needle. If you will see, this is the tip which is bevel shaped like this. This causes more dura damage. This one. This is called dura cutting, and this is what is called as a Quincke spinal needle. Dr. Harsh, you talk to me later. My Telegram ID is Dr. Vinish. You can connect to me on PW Medit, right? So we'll talk about that later, Dr. Harsh. Let me just discuss these points out. Dr. Med Psycho says bag and mask contraindicated in CDH children. Very nice, Dr. Med Psycho. Yes, it is. I did not see your message then. I just got it now. Okay. And Dr. Harsh will discuss about the point later. Let me finish off the revision for these guys. They are going to appear in the exam right now. Okay. So hopefully these people are prepared, and I don't want to waste their time because their exams are just around the corner, and my time is just so that the time that they're giving me, they should have a proper revision, fast image based, right? So this is what is called dura cutting Quincke. If you can see, this causes more damage to the dura and more CSF leak, right? Post-dural puncture headache is caused because of this kind of needle. To avoid that, we have dura separating needles. So this is the Quincke needle that you see, and this is what is called as the pencil tip needle for spinal, or it is also called as the dura separating needle, and this is what is called as Whitaker needle. Okay, this causes less PDPH. Now, this time in UPSC CMS, they asked you question about PDPH. This Sunday, the exam which was held, they asked you about the post-dural puncture headache. Okay, important point. I'm not going into too much details of that, but PDPH is caused because of what? Post-dural puncture headache is caused because of the CSF leak that you see. Post-dural puncture headache is seen because of the CSF leak that stretches the meninges. Correct. It will be seen in dura cutting, correct, and less in dura separating. That's why you're supposed to be using dura separating needles. So CSF leak which stretches the meninges, that is the reason for PDPH. What would be the treatment? Bed rest, fluids, give caffeine, give analgesics, but the most definite treatment is epidural blood patch. Okay, hopefully people are aware of that. All right. Now, when you give a spinal, what are the layers that get pierced? Very important. I'm discussing that spinal and epidural, the layers that get pierced. The first layer that you get here, is the skin. This is the skin. After the skin, you get the subcutaneous tissue. Some people call it superficial fascia, anything you can call. But I say it's the subcutaneous tissue. Then there's a line covering up the spinous process, which you called as the supraspinous ligament. Then you get the interspinous ligament in between that. After that, you get a ligament which covers up, this part. This is what is called as ligamentum flavum. As soon as you puncture the ligamentum flavum, the next thing that you get, this is what is called as the epidural space. So remember, the last layer before epidural is ligamentum flavum, right? Ligamentum flavum is the last layer before you get epidural. Until now, you're not in spinal, because then you get the layer which is dura. After the dura, if you can see, there's another small layer which is the arachnoid. So therefore, the CSF lies over here after the arachnoid. So this is where you give the spinal anesthesia, all right? Or you do the lumbar puncture. So therefore, the last layer before spinal is arachnoid, right? The last layer before CSF is arachnoid. This point is important. Before epidural, the last layer was ligamentum flavum, but before spinal or before the CSF, the last layer is arachnoid. Okay, that's exactly why spinal anesthesia is also called subarachnoid block. Okay, and epidural being outside the dura is also called extradural block. Right? Also, this is the reason that in case if you're giving a drug in the spinal, and if you are giving it above L1, you will cut someone's spinal cord. That is why spinal anesthesia is always given below L1, L2. And epidural lying outside is not near the spinal cord. I mean, of course, you can go and puncture the spinal cord. It will become dangerous. But You can give epidural, cervical, thoracic, lumbar and sacral, all. And sacral is called as caudal. Okay? Thumbs up everyone. Okay, Dr. Ajila says NSAID also, correct. So this is spinal, where you give a single shot drug or lumbar puncture. No, after the lumbar puncture, you give a drug. This is spinal anesthesia, right? This is the epidural, where you put a catheter. And that's exactly why it has got 1 centimeter marking, because you are supposed to puncture or go beyond the ligamentum flavum, but you are not supposed to go beyond the dura. You are supposed to stay here in the epidural space, and that is why you got that 1 centimeter markings in it. Okay, so that you know where you are, or almost where you are, right? So we've done all this, and major complications if we discuss for spinal. Okay, major complications of spinal. So you will have to discuss. The first thing that can happen is vasovagal. And vasovagal means someone collapses at the time of injection. There can be nausea, there can be shivering, but the most important is hypotension, and hypotension is accompanied by tachycardia, right? It's because of the peripheral pooling of blood. The level can go high up, which is called high spinal, and then there can be total spinal. So this is intraoperative basic complication that take place. Post-operatively, you get urinary retention, right? Damage to various structures that can take place, and post-dural puncture headache. These are important post-operative complications. So intraoperative and post-operative complications of spinal anesthesia. Done. Local anesthesia. Question: where does it work? Local anesthesia, where does it work? Which channels? Calcium, chloride, sodium, potassium. Anyone? A, B, C, and D. Local anesthesia works on which channel? So after this, I think I'll take I'll take capnography and all also. I'll just take those monitors, and I will also take sodium, says Dr. Ajila. Right. If you write Na, I understand. Correct. So sodium is correct. Correct. Absolutely correct. Okay. But remember, local anesthesia works at the sodium channels because it is working at the nerve or the nerve fiber. So it's working at the sodium channels. Right, Dr. Med Psycho, sodium channel only. Acha, then what is the disorder from calcium? Which disorder may calcium channel is involved? From anesthesia. From anesthesia, in which disorder you are getting, the problem with the calcium channel? Anyone? Fast. Sorry, I changed my question here itself. The calcium channel is involved in which problem from anesthesia? Very nice, Dr. Ajila, very nice. You are well prepared. Well prepared. This is what is called malignant hyperthermia. Malignant hyperthermia, it's a genetic disorder of the ryanodine receptor sarcoplasmic reticulum, and this is a calcium release channel. So malignant hyperthermia is a disorder of calcium channel. Asked in the exam, this is a genetic disorder. This takes place when someone has the gene and you expose this patient to volatile anesthetic agents or succinylcholine or lignocaine, right? Okay, so good point. Dr. Ajay have given good answers. So hopefully, anyone, all the people who are paying attention, see, just a revision that we are doing. So sodium channel for local. Also, one more point before I finish this point. Calcium we have discussed, malignant hyperthermia. Even the local anesthesia, though it's working maximum at the sodium channels, remember what it is doing is blocking the action potential from going forward. So therefore, it can work at all the channels. It can work at potassium also, calcium also, and chloride also. It can work at all the channels. All the channels. Right. Next point. Identify. What is this? As I said, I am going to discuss these in these monitors also, just in short, so that this is also getting covered. The image-based part from anesthesia, I think everything we have covered from the image part of it. From what I feel, but you never know, they can ask you anything. What is this? Yes, guys. Oh, उसपे लिखा भी है. I did not cover it. What is this called? This is what is called as bispectral index, right? Bispectral index is what? This is called as depth of anesthesia monitor. It tells you the depth of anesthesia. It is based on EEG. It gives a value between 100 to 0. 100 means the patient is awake. 0 means flat EEG. 45 to 65 is GA. 65 to 85 is sedation, right? Right, Dr. Ajila says where it is used. So this is used for depth of anesthesia awareness, right? Patient being awake and all. Correct, absolutely correct. Next, this question, FMGE only. FMGE question, January. This is what? This is neuromuscular monitoring. Okay. Which nerve is being observed here, or which nerve is being monitored? This is the ulnar nerve. Okay, that again is the most common. Ulnar nerve, and the corresponding muscle is the adductor pollicis muscle. Right? You are going to give 4 stimuli and you're going to get that response same way. Right? But if you find that there is non-depolarizing, you will get to see 1, 2, 3, 4. So this 4 that you see is what is called as train of 4. Train of 4 is the most common mode. This is what you see is called fade, right? In succinylcholine, what you get is lower amplitude, same height, right? You get less amplitude. This is phase 1, but the same fade is seen in succinylcholine phase 2. So this is telling about the muscle paralysis. It is the neuromuscular monitor. So basically what it is doing is you're going to stimulate the nerve over here and you are going to see the response over here, right? This is what is the neuromuscular monitor, right? Dr. Med Psycho says ulnar nerve. Good, Dr. Med Psycho. Nice. Next is the pulse oximeter, right? So this device is called the pulse oximeter. Pulse oximeter is based on the Beer-Lambert's law. What happens? You're going to give 2 types of light and there's a detector over here. So it passes through the blood vessel and it detects the oxygenated and deoxygenated hemoglobin and it tells you the SpO2, which you can see over here. Okay, it gives you the SpO2. Right? Apart from that, you get to know the heart rate. You also get to know the perfusion, the peripheral perfusion, based on which you come to know how is the blood supply taking place. The sites, finger, toes, ear, nose, and in pediatrics you can use that thenar, hypothenar, and sole of the foot. Right. So this is the pulse oximeter. Capnography, again important monitor. Capnography is the graph of carbon dioxide. So whenever carbon dioxide comes out, you get to see a graph like this. Right, CO2 is coming out. This means you have intubated the patient correctly, or correct ventilation is going on, or correct IPPV is going on, which means carbon dioxide is coming out. Carbon dioxide is coming out, right? Spontaneous. Someone breathing spontaneously. This tells you patient is out of muscle relaxant effect. Okay, which means patient was on IPPV, but now patient is breathing spontaneous. Okay, so this means that patient is trying to breathe spontaneously. Right? If you get a graph like this, means no carbon dioxide. So think of all the causes where there are no carbon dioxide, right? Esophagus, your tube is in esophagus, it got disconnected, accidental extubation, or even in embolism and all, where it slowly falls down. Okay, slowly it keeps on decreasing. So embolism, cardiac arrest, where you get like this, right? In fact, nowadays in ACLS they have added capnography as a monitor also. Capnography has been added as a monitor in ACLS. Okay, for to see the return of spontaneous circulation. We're not going to do too much details of that. This much is sufficient. You get a graph like this: malignant hyperthermia, fever, thyrotoxicosis, laparoscopy, and rebreathing. Right? When you get a sharp fin appearance, obstruction is taking place. Right? Correct. Dr. Metpsycho says sharp fin, and Dr. Metpsycho also said curare cleft. Correct. This is called curare cleft. Good, yeah. Dr. Metpsycho, you also prepared. Nice. Curare cleft. Correct. Sorry for my handwriting. Huh? I'm just trying to finish off fast. I'm like the doctors now who write like this. What is this? MCQ question. What is this? Identify. 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 What is this? No, this will not come in exam. Huh? This is out of exam question. Dr. Ajila says paracetamol. Why? I was writing pancuronium. I am from anesthesia. Understood? It can be like this also. Dr. Metpsycho also says PCM. No, I can be writing pancuronium. Why PCM? Yes, it can be PCM, but someone like me can write pancuronium also. Sorry, huh? That was just to tell you why my handwriting is like this. Okay, Cannulation. Now, talking about the anesthesia machine, the most important points here, the last thing that I'm going to take, right? Dr. Medpsycho is showing me a smile. Okay, are the colors and the pin index, right? Colors and pin index of these cylinders, which becomes important, right? So we'll discuss that also. So remember, colors and the pin index. So air, the color is gray with white shoulder and the pin index is 1.5. If you take oxygen, it is black with white shoulder 2.5, 2.5, huh? Nitrous oxide. If you take nitrous oxide, it is blue in color. Number is 3. If you take Antonox, it is blue with white. Number is 7. And if you take carbon dioxide, these are the 5 most important ones. Carbon dioxide, this is gray in color. The number depending on percentage of carbon dioxide will be 1.6 or 2.6. Okay. Nice, Dr. Medpsycho. I think you've mentioned those points. Correct. So these are the colors and pin index. They are very important, right? Colors for the desflurane. Now again, this was a question asked. Vaporizer. You'll find this. This is what is sevoflurane, yellow in color, right? Isoflurane, purple in color. Halothane, this is red in color. And light blue, this is desflurane. This is blue in color, but at the same time, can you see it's got a different shape? Again, this was exam question from FMGE. A special vaporizer because it boils at room temperature. It's got a special vaporizer, right? And this vaporizer is electrically heated. You'll find electrical supply also. It's electrically heated, right? Electrically heated. That is desflurane. Remember, the shape is different from all other types of vaporizers, and this question was asked in the exam, right? On the anesthesia machine, because these cylinders are used in emergency, you've got a pipeline supply also coming, right? Pipeline supply. These pipelines also have those colors where you will find oxygen is always white in color, nitrous is always blue in color, right? This black is air, and air is provided where we use it in anesthesia, like in laparoscopy where we don't use carbon dioxide, and this is vacuum, which is yellow in color, right? The yellow color that you see is called vacuum, which is used for suctioning. These are the pipelines. Okay, right? Dr. Medpsycho says unique shape, that's fluorine. Correct. So we have done that. With that, let's discuss the breathing circuits, right? Breathing circuits. Mapleson A. So here you have to remember Mapleson A is called as McGill circuit or Lack circuit. This is used for a spontaneously breathing patient. Mapleson B, they won't ask you, obsolete. Mapleson C also not used anymore. People have used it for chest physiotherapy and all, now not used. Mapleson D is what is called as Bain circuit. It is used for IPPV. Mapleson E is what is called as Ayers T-piece. Ayers T-piece. And this is used for a neonates ventilation. It is used in ICU to wean the patient off ventilator. Mapleson F, this is called as Jackson-Rees circuit. Okay, this is used for pediatric patient, correct? Junior. So Jackson-Rees is Jackson-Rees circuit, REES, Jackson-Rees circuit. Mapleson D most common? Yes. Out of all the circuits, this Mapleson D can be used for IPPV as well as spontaneous, and therefore Mapleson D or Bain circuit is the most common used, right? Most common. Correct. Mapleson D. Absolutely. This is what is called as closed circuit. Closed circuit is where you're using soda lime. Soda lime is something which absorbs carbon dioxide. Okay? Soda lime absorbs carbon dioxide. Therefore, soda lime has a capacity to absorb carbon dioxide, and after some time this will get exhausted, right? How will you come to know that it is exhausted? You will come to know from the clinical signs, right? Increase in carbon dioxide, and you will come to know from the color change. Important. So this is the closed system or the circle system, right? So this is the, remember, so this is the closed system or the circle system where we are using soda lime, which is something that absorbs carbon dioxide. Right? Color change. Correct, Dr. Ajil. I think you're done. You're well prepared. Now, let me just discuss one important point that I want to put forward, and that is regarding Malampatti classification. Right? Another important question which comes from here. So, Malampatti classification, guys, this image also has been asked. Remember, Malampatti 1 is where you can see the complete uvula. Okay? You see the complete uvula. You see the tonsillar pillars, you see the fosses, you see the soft palate and the hard palate. Malampatti class 1. Malampatti class 2, the tip of the uvula is not seen, right? Half of the fosses and tonsillar pillars are seen. Soft palate and hard palate are seen. Malampatti class 3, the base of the uvula is seen, but you can't see these pillars and fosses. Soft palate and hard palate are seen. Malampatti 4, only hard palate is seen. So Malampatti 1 and 2, they correspond to relatively easy intubation. So when you put a laryngoscope, the vocal cords are kind of visible with the Cormack-Lehan grading. So this is the Malampatti grading. So Malampatti grading tells you what? When you do a laryngoscopy, will you be able to see the vocal cords and intubate? So this is how you see the vocal cords, right? So it helps in laryngoscopy and intubation. Ease of intubation. Malampatti 1 and 2 relatively are easy intubation because here vocal cords are seen. Malampatti 3 and 4, vocal cords are not seen. So Malampatti 3 and 4 become difficult intubation. Right? Correct, Dr. Med Psycho. Okay, guys. And what I need to do last is to tell you other people. Okay, sorry, before I say thank you. Any questions and doubts, guys? So I try to take it for an hour and try to finish off most of the questions, kind of complete revision. As I said, I have not done the drugs over here, but rather than taking 10 questions, 15 questions or 20 questions, I thought of discussing in terms of image-based diagrams which are there. I discussed all the image-based. Most of the things are covered. And this is the name of the test which is going to be there on the app. If there are any questions, you can ask me right now. I'll take them. Dr. Med Psycho says, if Malampatti 3, let me take the mobile up here. I'm bending down each and every time. So you're seeing me go down and up, down and up. Sir, if Malampatti 3, 4 is there, do we need to do urgent tracheostomy? No. Dr. Med Psycho, very good question. Dr. Med Psycho ka bahut acha question hai. Let me explain it here. Dr. Med Psycho, the meaning of Malampatti 3 and 4, it means that we are doing it during the pre-anesthetic checkup, right? So when someone has come for a PAC for a surgery and I find Malampatti 3 and 4, I know this is going to be a difficult intubation. So you are right. I will not do immediate tracheostomy. So when this patient comes for surgery, maybe after 3 days, when he's planned after 3 days, till then I will keep my set for difficult intubation ready, which will include LMA, which will include fiber optic, which will include tracheostomy set, and many times I might even ask for an ICU bed, right? So this is the point. What helps me is that from an anesthesia point of view is that this Malampatti grading pre-operatively means before the surgery, not on the OT table, not on the OT table. Like if you enter the OT table, suddenly you can't intubate someone. But during the pre-anesthetic checkup, which is my OPD, anesthesia people have the OPD, which is called PAC OPD. Pre-anesthetic checkup is where we see it, and if we find that it is Malampatti 3 and 4, we write it on the PAC sheet, and whosoever is going to be there in the anesthesia department that day, the person knows it is difficult intubation, and so we keep things like laryngeal mask airway, or Airway Supreme, the newer things which are there, fiber optic devices, right? Tracheostomy set, all these are kept. Dr. Gajendra Yadav says LMA Procil. Correct, LMA Procil also. I'll say intubating LMA also. You keep something called as intubating LMA also. But that's a very nice question from Dr. Med Psycho. Okay? Yes, guys. Anyone else? Any other question? कोई question, कोई doubt, कुछ पूछना चाहते हो तो let me know. Thank you. The session was very nice. You people were very interactive and I liked it. Dr. Med Psycho says, thank you, sir, for doubt clearing session. Thank you. Thank you, Dr. Med Psycho. Thank you so much. My point was at least just revise. I didn't want to do it in the form of questions because I know your exams are coming up. So it's no point that I take your time and just discuss 15, 20 questions or 30 questions. I wanted you guys to go through anesthesia and straight away appear on that day. Okay. Thank you, Dr. Parul. Thank you, Dr. Ajila. Thank you, Dr. Med Psycho. It was wonderful. And you people have our app, my number and all. So my Telegram ID is Dr. Vinish. You can connect with me on that. Any questions you can forward or ask me at Dr. Vinish. That's my Telegram ID. Okay. All the best, guys. Do well and don't worry. Okay. Believe in Almighty. Okay. Thank you, parents. Parents are the most important. Remember, I told you FMG students. Parents kuch hote hain, but FMG students, when you clear your exam, the happiest people that I have seen in so many years are your parents. Then there is no one who's more happy than your parents. So you people need to clear for your parents. As simple as that. Okay. Don't have a negative thought in your mind. Just clear, do well, and all of you will be doing well. Okay. All the best. Stay connected, and when you clear, let me know. You have my Telegram ID. Thank you guys. Good night and all the best.